Thanks for the invitation. In the following 20 minutes, I will try to examine which advantages can offer data federation in stroke. I have no conflicts except that I'm co-chairing the guideline production group within the European Academy of Neurology, so of course I have a specific interest in approaching the FEDER project for the purpose of evaluating guideline implementation. This is the outline of my presentation. I will overview some advantages that federating data in stroke can offer with some examples. I will speak a little more about guidelines implementation, and also I will pinpoint some challenges. The first advantage is somewhat obvious: sample size, and the large sample size that federating data make available. The FEDER project will allow for about 500,000 patients, and there is no need to make a sample size calculation to say that this number would allow for analysis of several variables alone or in combination. As a rule of thumb, a multivariable analysis requires 80-100 cases per variable. Machine learning models learn the relationship between data through the correlation of features, what we usually call variables. And the number of cases available per feature is called sample-to-feature ratio. Is a simple way to assess whether the sample size is satisfactory for a given model. A sample-to-feature ratio of around 15 is considered the minimum, and the FEDER project will allow a number of cases absolutely sufficient for working also with complex machine learning models. Of course, other considerations apart of sample size will apply to estimate the value of any association, for example, the minimal clinical importance. With these numbers, many analyses will become possible. Oppositely, I will not speak about the classical registries analysis of incidence, prevalence, trend, seasonal variation, or about the classical clinical prognostic analysis. On the contrary, I want to focus on three aspects that can be outlined as a direct consequence of a large sample size and the widespread distribution of registries that FEDER will make available: analysis of clinical practice, major inequities, and predictive models in real world. The first is the possibility to compare data from different geographical areas to study aspects of stroke care that are related to the different clinical practice and health systems across Europe. Interstroke is a good example. Interstroke was an international case control study of risk factors for first stroke, which enrolled more than 30,000 stroke patients from 140 clinical sites in 32 countries. The study hypothesis was that there will be variations in the access to stroke treatments and services across countries with different incomes, and that after adjusting for case mix, patient outcomes will be affected by the treatments and the services they can access. I don't want to enter in the specific of results, but this example is useful to see what type of data they collected. And as you can see here, most of this data, if not all, are easily obtainable from our registries. This is the type of analysis comparing different characteristics in high income country, upper middle income country, and lower middle income countries. Second possible field of study using federating data is that of inequities in stroke. There are several major inequities in stroke: racial or ethnic, gender, geographic, and socioeconomic. This is a meta-analysis of risk of death in stroke according to one of these inequities, the socioeconomic status, which is defined by only two variables, education and occupation, which are easily ascertainable in our registries. And of course, the same is possible for other inequities. Federated stroke data also allow for studying complex predictive models, including the classical clinical variables, together with demographic, socioeconomic variables, but they are prone to a unique opportunity to compare different clinical practice in the real world, including, for example, the volume of activity, the size of a hospital, specialty of caring doctors, and several other aspects of health policy. For example, comparison of public versus private hospital, general hospital versus academic hospitals, and so on. There are several examples of this. I want just to show you one. This is an Italian survey where you can clearly see a progressive decreasing of mortality in relation to the volume of activity. These headings are in Italian, but I think they are easily understandable. This is not obvious for all diseases. In the left side here, you can see the same analysis for myocardial infarction and for lung tumors. And you see, for example, here that there is decrease immediately, but after there is a plateau without no progression depending on the volume of activity. So also here, federating registries could give a large material of study for studying clinical practice determinants of the outcome. The third example is that of the study of exposome. New technologies allowing to capture and increasingly giving views of different exposures are getting more and more available, and they vary from satellites that sense chemicals to environmental markers of pollution, temperature, and many others. Here is the example of Google Street Car equipped with air pollution sensor in Oakland, California. They produced a very detailed map of air pollution that is collected in a data bank and available. And you see here. Increasing amount of data is accumulating, and now there are several data banks of environmental exposure that are available in many European countries, making available data on air and water pollution, temperature, meteo conditions, solar irradiation, traffic noise, and so on. This is a recent example from Scandinavia that shows a relationship between the risk of stroke and the amount of traffic noise. A federated stroke platform can point to other platforms or external data, either at a central level or at the level of single hospital. This could produce new and exciting data, but requires computing facilities and data analytics that may not be available at single center. Think, for example, to some artificial intelligence algorithm that may run on the central powerful machine, which is not available at all local levels. The central governance of a federated registries may offer this kind of service. And finally, what we as European Academy of Neurology are interested more is the possibility to evaluate the implementation of guidelines in the real neurological world. Many countries, as you see here, have now their own stroke guidelines, but if you perform a literature search on guidelines implementation and, more importantly, on the effect that guidelines have on outcomes, you found only rare and sparse studies. A recent literature review found only 27 studies assessing the adherence of stroke to stroke guidelines, and only 16 were evaluating generic stroke guidelines. The others were devoted to single specific problems like thrombolysis, mobility, nutrition, etc. And you see here. However, most of these studies were done outside of Europe, and only 5 of these studies really evaluated adherence as it is, as a photograph of a situation. And all the others dealt with interventions to improve the adherence. So, Europe is completely lacking studies evaluating adherence to guidelines. And FEDER has all the requirements to uncover if there is a gap between evidence and practice, which I think it is. There are several reasons creating barriers to adherence, including lack of familiarity of guidelines, lack of motivation, lack of time, resources, a perceived difference in the quality of guideline, but all this is out of the scope of my presentation. What is the possible advantage from FEDER project in understanding what is the adherence to guidelines in Europe? We have in Europe so many different clinical contexts that, to my vision, federating data from different sources across Europe could be an extraordinary possibility to evaluate adherence in relation to these different practice concepts. I'm just citing here the from the project application. And of course, this is not an easy task. It needs a lot of work for definition, homogenization, and evaluation of different indicators. But it is possible. Several indicators have been used in other studies and can be replicated in FEDER. I list here only some of them. For example, time to thrombolysis, or the percentage of FA patients treated with anticoagulants, or the percentage of hypertensive patients treated, and so on. Of course, these indicators will not be available in all registries or hospitals, but many of them will be and will allow for several comparisons. We also may think to translate some PICO questions. Here you see a cartoon of a process of guideline production, and PICO question is one of the first step. And I see the possibility to use some PICO clinical question derived from guidelines in indicators that can be counted. Last, adherence to guidelines will have no meaning if it does not improve outcomes. Unfortunately, studies considering the connection between implementation and outcomes are even less than those studying simple adherence. The study designs to evaluate the possible effectiveness of adherence are not easy nor simple. I want to show you just 2 examples. The first thing on the left is a pre-post study in which the authors implemented stroke guidelines through a specific initiative and compared the outcomes 12 months before and 6 months after the initiative. And as you see, if you compare the full line, which is before, and the dotted line, which is after, there is a clear improvement in all the 4 time-based outcomes they considered. For example, the indicator is the minutes to alteplase, or here the indicator is the minutes to initiation of CT scan head. On the right, you see another example. This is the Get with Guideline Stroke program, which is a large implementation program in almost 800 US hospitals. And here you see the percentage of patients who received each of 7 evidence-based measures, and you clearly see an improvement in each of the 5 years of a project. So further, we'll have a possibility to relate several key performance indicators to outcome, and also to monitor any possible improvement across time. This is an incredible opportunity for years to come. I would say this is maybe a real-time monitoring. However, there are also some disadvantages in data integration, but I will prefer call these challenges more than disadvantages. The first is that data collection differs among centers, not only because centers collect different data, but also because the same concept can be expressed and labeled in different way in different databases, depending, for example, from country, language, custom, and so on. So data heterogeneity is one of the critical problems in analyzing, reusing, sharing, or linking database. And this regards coding data, clinical data, lab data, and so on. Creating a minimum dataset and ontology are the tools for overcoming this problem. Ontologies are a set of formal concepts, or called entities, defining a specific domain of knowledge, which indicate properties of these entities and the relationship between them, including, for example, the question how entities are grouped into basic category. At the end of the day, to an extreme simplification, ontology is nothing else than a complex dictionary of terms. If you think to ICD-9, this is a very old example of ontology that we all know very well. But there is a dedicated section in this symposium held by specialists, so as a clinician, I will not discuss this further. In that section, 2 other important concepts in aggregating data will be discussed. Knowledge graph, that designs the links between different terms of ontology, and metadata, that is the information on data, not the real data, but the information on data stored in the platform of a federated architecture. There are several examples of ontology, and here you can see a repository of different ontology that you may explore in the internet if you want. As a clinician, I will concentrate on 2 other classical problems regarding data quality when you work with data from different sources. And I will show you 2 examples from personal data derived from the analysis of ICD-9 codes in administrative data. This does not apply perfectly to registries, but can give an idea of a problem. The first, here on the left, is an analysis of sensitivity and positive predictive value of different ICD codes for stroke. And it is interesting to see that the positive predictive value is much higher than the sensitivity, which means that ICD codes do not intercept all strokes. TIA, there is a high percentage of false negatives. But when you find a code 43043.8, that's very likely to be a code for stroke. So there is a low percentage of false positive. The other point that is interesting is that there is a clear difference between hemorrhagic and ischemic stroke, and this is a point that must be taken into consideration with dealing with any coded data for stroke. The second crucial issue here is reliability or reproducibility, which must be measured as inter-center and also as intra-center variability. In this second study, we gave the clinical charts of 53 patients to 4 residents, 4 neurologists, and 4 experts in coding, and asked them to code. And as you can see here, the agreement was good for hemorrhage stroke, but not so good for ischemic stroke. So also this is a crucial point to take into consideration when we deal with federating data. And I will stress that it is absolutely necessary to have an idea of the size of a problem as a whole and for specific categories. I hope to have been able to give you an overview of what are the possibilities of federating data and also some caveats as well. And I am happy to finish my presentation with this old slide that make clear an added value of integrating working, not only for human relationship, but also for optimizing and spreading of procedures and idea. Thank you for your attention.